in school.
Right, yes.
In school.
Okay, so yeah, we're about to start now. Okay, so thank you everyone once again for coming to or attending via virtually via Zoom to the second day of our health symposium. And this morning, we're very delighted to have a panel of three very excellent and established speakers. First is Associate Professor Douglas Story of Johns Hopkins University. He is a behavioral scientist with nearly 40 years of work in health communication, and he worked in over 36 countries, including many countries across Asia. And he has worked on many interesting topics on social and behavioral change related to reproductive health, family planning, and so on. Right. So as you know, as with all these eminent scholars, you know, we'll take a whole day just to read out their publications and programs. So, let's move on. So the second speaker is Dr. Aika Basnet, who is assistant professor at James Madison University of Virginia. Prior to this, she actually spent a number of years in the Department of Communication at NUS. So probably that's why I might have find her quite familiar. So I was a graduate of that program as well. So she has worked, her work has published in Com Theory, Health Com, Journal of Health Communication, Cultural Health Sexuality, Qualitative Health Research, among others, right? And our third speaker today is Dr. Evelyn Ho, who is a professor of Communication Studies, Asia Pacific American Studies, and Critical Diversity Studies, and faculty chair of the Honors College at University of San Francisco. So beginning with understanding of communication as a cultural activity, and that healthcare systems and beliefs are profoundly cultural. Professors Ho's teaching and research focus mainly on intersections of health, culture, and communication, with specific emphasis on use of cultural meanings and acupuncture and Chinese medicine in marginalized populations. So I believe we'll have a very diverse and meaningful discussion today. So without further ado, may I invite Doug to begin? Yes?
Thank you. And I'll be able to share my screen?
Yes, you will.
Okay, I will do that. And I'll have to go back up to the beginning to start. And okay. So thank you, everyone. It's really a pleasure to be back in Asia. I love working in Asia, and I've been to Hong Kong a number of times. I really miss not being able to travel these days. What I'd like to talk to you about today is a model that we use a lot at my center, the Center for Communication Programs at the Bloomberg School of Public Health, called the ideation model. And I'm going to give you a very brief introduction to what this means and sort of how we use it. But then I'm going to illustrate it with some data, some very recent data from a global survey about COVID-19 knowledge, attitudes, and practices called CAP COVID. And I'll talk a little bit more about that as we go along. So the basic idea here is the concept of ideation, which comes out of some work in the 1980s by a couple of demographers, John Cleland and Christopher Wilson, who were trying to understand why some of the current models of demographic change were not able to predict changes in fertility rates around the world. And so they proposed a new model that incorporated psychosocial variables, and they defined it in their work as new ways of thinking and the diffusion of those ways of thinking by means of social interaction in local, culturally homogeneous communities. It sounds a lot like diffusion, if you're familiar with the diffusion model. But Cleland and Wilson never really operationalized this very well. They argued for the use of more psychosocial variables in economic, demographic models, change models, but they never operationalized it. And then a few years later, along with my colleague, Larry Kincaid, who I think all communication scholars should know more about, extended this model and applied it in a lot of the work we were doing at the time on family planning and contraceptive use. And we added to their model the notion that these ideas can also be spread and shared within culturally homogeneous communities through mass media. Um, so the sort of the basic visual for this is the simplest sort of way of picturing this is to imagine a kind of star shape in which a variety of psychosocial variables combine to influence the behavioral choices that people make. And these include sort of typical things like knowledge of what the behavior entails or what the health area is about, knowledge of things that you can do, behavioral options that you have, attitudes about the consequences of those behaviors, how you imagine yourself as a healthy person, as a responsible parent, as a supportive husband, perceived risk, that is the threat, susceptibility and severity of particular disease challenges, social norms, what you think other people think, and what actually happens in the social world around you, your own self-confidence or efficacy to practice this behavior effectively, sometimes emotional reactions that you have associated with the behavior or with the setting in which you find yourself, interpersonal influences, the conversations that you have with family members, with neighbors, with religious leaders, political leaders, community leaders, and so on. And then personal advocacy, which refers to whether you talk about this behavior and promote its use or its practice to other people. So there are a lot of factors, and these are just sort of buckets of psychosocial variables that can be further elaborated and detailed in a particular cultural context. So wherever this behavior is happening, you would want to identify the particular aspects of knowledge and attitudes and risk perception and so on that are relevant in that particular setting. Now, another important thing to note about this ideation framework, the way we use it, is that these factors often simultaneously influence behavior. So it's not a matter of finding the one that makes a difference. Often it's a matter of finding a combination of these factors that are most relevant in a particular setting for a particular group of people. And you can also think of these as kind of something like the obverse, the inverse of risk factors for cardiovascular disease, right? The more risk factors you have, the more likely you are to suffer from cardiovascular disease. This works in the other way around. The more of these factors you have that are positive, the higher the likelihood that you will practice this behavior. So, sorry, I gotta get my, oops, sorry, it did move. So just one very, very brief example to show how this is localizable. These are some data from a study that was done 20 years ago by Larry Kincaid in the Philippines. There was a national communication campaign promoting family planning. And normally when we apply this model, we would go through a qualitative research phase. We would do an in-depth qualitative assessment of what the potentially relevant ideational factors are, and then use those to build our cumulative ideation model. And in the Philippines, just to show you how some interesting localized ideas emerged, there were about 10, I think there were 8 or 10 factors that were significantly associated with the use of contraception in the Philippines at that time. And the top 4 are the ones you see here: self-efficacy, discussing family planning with friends, having friends who encourage you to practice contraception. But the one that was the strongest predictor of contraceptive use is a Tagalog word, hiyang, which means just right for me. So you can have a food that is just right for you, or a type of movie that's just right for you, or a fashion that's just right for you. People who believed that there was a contraceptive method that was just right for them were much more likely to adopt a method of contraception. And you can see on the on the left side of the screen that as you add these factors, the more of these factors you have working in your favor, the higher the percentage of people in that category who practice contraception. So if you have all four of these factors, among the people who had all four of these factors working in their favor, 62% were reported practicing contraception, compared to 23% who only knew about methods that might be key-on for them. So you get a sense of how you can use this to build a cumulative scale, as well as to identify unique cultural characteristics or beliefs and knowledge and attitudes that may be related to the behavior that you're interested in encouraging. So let me turn my attention now to this worked example. And I know our time is limited, so I'll keep moving. And please note any questions you have, and I'm sure we'll come back around to those a bit later. So the data that I'm going to show you here comes from a global knowledge, attitudes, practices survey called the CAP COVID survey. This is a multi-wave data collection exercise that's being conducted through a collaboration between Facebook, which is funding this activity, my center at the Bloomberg School of Public Health, the Massachusetts Institute of Technology, WHO, and the Global Outbreak Alert and Response Network. So we've come together to support this multi-wave survey in about almost 90 countries around the world. The surveys, there are two types of surveys. There are snapshot surveys that have only been done a couple of times in about 67 countries, but 23 countries, including 8 in Asia, have been surveyed every 2 to 3 weeks since early July. And the latest data that we have, which I will talk to you about this evening, comes from a wave of data collection that ended on the 25th of February. So, as I said, there are 8 Asian countries that we call the wave countries, and another 15 that, and a total of 15 that were included in that snapshot survey, one in July and then one most recently at the end of November. So globally, this survey has captured responses from over 1.5 million respondents since July, including over 500,000 from Southeast Asia and East Asia and the West Pacific. So what I'm going to show you now comes from these 8 Asian wave countries and the most recent wave, 16 from late February. If you go to this website, which I strongly encourage you to do, this is really a fascinating resource. The dashboard presents a number of different options for visualizing the data, both at particular waves and over time for trend analysis, and it allows you to tailor your visualizations to the particular locations you want to understand better, as well as the specific items in the survey to see how they have changed and how they might compare across countries. So I won't go into detail here, but I'll show you some of the data that I've applied for this ideational framework. And the most recent addition to the dashboard is a really fascinating longitudinal visualization tool on global vaccine acceptance. So if you're interested in any of these topics, I strongly encourage you to go to this website and play with it to see what you can do with it. It has lots of terrific implications for strategic communication planning. Now, there are a couple of limitations that I have to acknowledge in this survey. Besides some of the issues with sampling through Facebook invitations that can lead to some skewed, sample profiles. The sample is corrected to some extent, weighted to match the socioeconomic profile of the country where the data comes from, but it's not a perfect correction factor, but it's not bad. But the survey is limited in length. You can imagine a survey of this length, many people trying to answer the questions on a mobile phone. It can't be a long battery of questions. So it limits the number of questions we can include. And so rather than tailor the ideation questions to the country context as we would normally do, we've used a set of standardized ideation variables for all the countries that participate in the survey. And then there has been some randomization of the blocks of questions that are presented to a person who agrees to participate. And that creates some issues with being able to build a comprehensive ideation model, because not all of the questions are asked of every person in every survey wave. So there's some limitations to how flexible we can be in building a really comprehensive ideation model. Nevertheless, what I'm going to show you now focuses on 7 variables, psychosocial variables in the survey, among many others, that represent some of these different categories of ideational factors that I described at the beginning. So we have a couple of knowledge items, whether you know 3 or more of the symptoms of COVID-19, whether you know correctly which groups are more at risk, such as the elderly or those with pre-existing health conditions. We had 2, I'll show you 2 response efficacy questions, one referring to whether you believe that masking is an effective behavior to prevent COVID-19, and the other, whether you believe that physical distancing is an effective way to prevent COVID-19. So this is a belief in how well these preventive practices work. There are 2 descriptive norm questions that I'll use to illustrate this application of ideation. One is the perception that 50% or more, a majority of people in your community practice masking correctly. The second is whether you perceive that the majority of people in your community practice physical distancing. And then the final item that I'll use to build this scale to illustrate ideation is an injunctive norm question that reflects the belief that the majority of people in your community approve of community action, community collective action against COVID-19. So we have 7 variables, and the way that we build our ideation scale is to dichotomize these, so create a 0, 1 value for each one, whether you do or don't know the 3 symptoms, 3 or more symptoms, and so on. And then we create a cumulative index that counts the number of these variables that for which you score 1. So the number that are positive in your favor. And just to show you that these do vary considerably across country, I'll just flash a couple of these variables that we've used to build this particular ideation score. And you can see that there's considerable variation. In terms of knowing which groups are at risk, the lowest of these 8 countries is Indonesia. Only 27% of people answered that question correctly, compared to 54% in Japan, and the others fall somewhere in between. For response efficacy around distancing, Japan had the lowest percentage of people saying that distancing is an effective way to prevent COVID. Highest in Malaysia. In terms of this descriptive norm around distancing, the majority practicing distancing, the lowest was Pakistan, the highest was Malaysia. And then the injunctive norm about majority approval of community collective action, lowest in Pakistan and highest in Vietnam. So you can see that these do vary across different national cultural contexts. And so when we combine these, we can use this combined score, which would range from 0 to 7 if you had none of those factors in your favor, and 7 if you answered all of them correctly. We can use them to predict protective action. And the outcome measure that I've used here is composed of 4 different protective actions that are also asked about in the survey. Regular hand washing with soap or use of sanitizer, wearing a mask or face covering in public, maintaining at least 1 meter distance from others in public, and self-isolation in the past week as a way to, if you suspect that you might have been exposed. And then for logistic regression, we collapse this into whether people reported 2 or fewer of these 4, or whether they reported 3 or 4 of them. So that's the outcome measure that we're using as that we regress on to show the effects of this ideational score. So Here's a slightly complicated table, but I'll sort of talk you through some of the salient aspects of this. This shows the ideation model for each of those 8 countries: Bangladesh, India, Indonesia, Japan, Malaysia, Pakistan, Thailand, and Vietnam. On the left side, you see the variables that were in this multivariable logistic regression predicting whether you practiced 3 or 4 actions or less, with some demographic controls: gender, urban residence, age, over and under 30, education level, knowing someone who has gotten COVID-19, and self-reporting that your own health status is good. And then we have the 7 ideational variables listed here that I just described. And in the columns are the odds ratios for each of these variables in the model for that country. So there are a number of things that you can observe here. Like the demographic variables don't seem to make much difference in Bangladesh, but in India, gender and urban residence are related to whether you take action. In Indonesia, it's education, and in fact, lower education. You're more likely to practice it if you have less education in Indonesia. Knowing someone who has COVID-19 is positive, and you can sort of see that the other countries vary somewhat in their pattern of demographic factors that influence the behavior. And then when we come down to the ideational block or the ideational rows, again, you can see that odds ratios vary considerably across the countries. In some cases, that variable is not significant, like knowing the symptoms is not a significant predictor in Vietnam. In some countries, more of these factors are relevant: 5 in Japan, 5 in Pakistan, 5 in Thailand, only 3 in India, 4 in Bangladesh. And again, you can sort of begin to see some possible opportunities to think about messaging based on differences in which ideational predictors are significant and how strongly significant they are. So now I'm going to, oops, I didn't go ahead. Okay, here we go. Yeah. So let me show you a couple of these cumulative ideation curves, and I'm almost finished here. I know I'm probably at the end of my time, but this series of what I call ideation curves shows the percentage of people who report that higher level of action, reporting 3 or 4 of the 4 predictive actions, by level of ideation. So in Pakistan, for example, people who had no positive ideation factors in their favor, among that group, only 1% reported taking 3 or 4 actions. But as your ideation level goes up, that is, as the number of positive factors you have operating in your favor, the higher the probability that you will report practicing 3 or 4 behaviors. To the point in Pakistan where if you have all 7, 80% of the people in that category report that higher level of activity. Now in Malaysia, you see again this kind of trend. It's a fairly strong linear trend, very consistent, and you'll see that in a couple of other graphs here. But you might note that the increase is somewhat steeper in Malaysia and somewhat slower or more gradual in Pakistan, which indicates that to reach higher levels of protective practice, it's necessary to overcome more of those ideational barriers to get people up to that level of protection. In Malaysia, for achieving success in promoting at least 4 of those factors already meets brings people to the same level as all 7 factors do in Pakistan. So there are clearly there's some cultural drag, perhaps, is a way to put it, in some countries where more factors need to be overcome in order to achieve higher levels of outcomes. Similarly, in Bangladesh, it's a more gradual curve here, and ultimately the likelihood of practicing those more advanced or more protective actions is lower on average than in the case of India. And then just to finish out the picture, here are the curves for Indonesia, for Thailand, for Japan, and for Vietnam. And I would just point out that this does illustrate how powerful that ideation, that cumulative ideational model can be. If you can identify what these important salient factors are and promote them using effective communication, it's clear that there is a cumulative effect on achieving those desired outcomes. And so I'll end with just a couple of thoughts about what some of the implications for communication strategies are. As you saw, there are some countries where certain ideational factors are relatively weak, fewer people report them. And so one strategy might be to identify those variables that are weak in a particular location. And this doesn't have to be at the national level. You can do this ideational analysis at a smaller level of social aggregation, sub-districts, sub-national regions, and so on. But then you could focus on those that are lower than you would hope they might be. So for example, there were low distancing norms in Pakistan. So you might try to create messaging that tries to encourage more normative practice, or if there's a gap between the perception and between the actual practice of that behavior, you might point out that difference. Another example is the low knowledge of risk groups in Indonesia. So by increasing knowledge of who is at risk, we can help to raise that ideational score and increase the likelihood of action. Another way to apply this is to think about just increasing the overall number of positive ideational factors. You saw that in some countries, there were 5 significant ideational predictors, in others fewer than that. So we might try to simply increase the number of factors that are positive in order to boost the likelihood of having that cumulative effect. And then finally, you might think about the variables that have high odds ratios, that is, have high predictive value, high association with the outcome and in a particular country, and then maybe focus on messaging around those variables for subgroups who are underperforming. Think of underperforming. So for example, men in Japan are less likely to be reporting these the more active protective measures, and distancing norms are an important ideational variable in Japan. So trying to address distancing norms for men may have particular value in increasing the prevalence of those behaviors among men. And masking efficacy for the people under 30 in Malaysia was also a gap. So we might try to encourage younger people in Malaysia to recognize the protective value that face masks do have. So I'm going to stop there. I've probably run way over my time, but I thank you for your attention. And if you would like more information, I'd be happy to receive emails from you. And I encourage you to check out the dashboard and explore these data for yourself. Thank you very much.
All right. Thank you very much, Doug. Now, moving on to our second speaker, Aika, please. Yeah. Icha, sorry, Icha. Yeah.
Okay. Can you, my screen's working, right?
Isha, we can see your next slide. So maybe you want to full screen.
Wait, how's that happening? This is the one I want.
It's okay if you don't put any notes there. We don't mind. Okay, now it works.
No, I don't have any notes because I'm going to read it to you. I'm happy to be here. Thank you for joining in. And you know, as everybody said, it would be great if we were in person, but obviously this is probably safer for now. So hopefully we'll have an opportunity to do this in person. I'm gonna take a sort of a micro view, and it's a great follow-up to the conversation that Doug just had, giving a broader conversation in Asia. I'm gonna dive a little bit more in a micro context and thinking about it in that sense. And I want to begin with just something that was talked about yesterday, which is just the fact that health communication has and continues, right, to be predominantly focused on individual behavior. This was something that came up in the panel and also a discussion in terms of how we have, right, traditionally been and still continue to focus on individual behavior. Another thing that also came up is that, culture, focusing on culture gives us a, particularly for me, right, taking a more culture-centered approach offers a alternative point for theorization and methodological approach. And again, the second panel really talked into this. So just, I wanted to connect to yesterday's conversation as we move forward in my focus today on the intersections of culture, gender, and health. And another thing that also came up yesterday was that a need to increasingly think about the Global South, right, as an entry point for theorization. So instead of wholesale taking ideas and models that were derived in the North and bringing it to the Global South, kind of thinking about the cultural spaces, the cultural context, and thinking about those micro spaces and deriving theory-based research in that way. So the example that was just presented here, even if you did a cross-cultural comparison, right, kind of locating in that space. But I'm going to take that one step further and talk about the fact that we still have to also consider an intersectional framework in health communication that is not often happening. At this point, some of you may think, well, I mean, don't we do that when we think about something like social determinants of health, right? We're already looking at different ways in which health and social aspects of health, right, are intersected when it comes to health behavior. So, you may be thinking, haven't we moved from thinking about just behavior to kind of thinking about the social environment in which that behavior encompasses? And I wanted to also point this out before I moved into convincing you that there is a need to take this further into this intersectional approach. And that is, yes, right, we are looking at social inequalities when we look at social determinants of health, but right, we often do this in isolation, meaning that each of those things become an additive variable. We're still focused on the individual behavior, and we have taken this model from science and adopted it into social science. And we don't necessarily look at how and the ways in which all of these inequalities simultaneously impact somebody's health risk, or health behaviors, right? And so, that's where I'm going to focus much of my discussion on today, but I just wanted to sort of lay this background in our conversation to help understand what I'm talking about and where that comes from, so that there is a reference point. All right, so what I thought I would do before I talk about the specifics about the intersections of culture, gender, and health, to start with this question: how do different aspects of culture intersect in shaping a health discourse, particularly in the context of gender? And I wanted to do this by reading an excerpt. And as you listen to this excerpt, I just want you to be thinking about what are the ways in which culture is intersecting here, right? Whether you're looking at it from an individual behavior aspect, whether you're looking at it from a social determinant aspect, or whether you're really thinking about the gender aspect of this story. Right. Parvati is a 44-year-old HIV positive woman with 2 young children. During the time she learned of becoming HIV positive, changing economic status had impacted the work patterns and in turn increased domestic and international labor migration among men in search of jobs. This contributed to the practices around sexual relations, one of them being presence of multiple partners among men due to spousal separation. Men framed their sexual encounters as companionship when traveling for work, and HIV as bad luck. On the other hand, fear prevented women from disclosing their HIV positive status in the family and community. In fact, HIV status has led to discrimination and fight for survival due to loss of social status and financial support for women. Restricted social autonomy of women, such as requiring consent from the spouse, reduced Parvati's ability to access sexual health and HIV services, Further, discrimination from service providers that stemmed from views around female sexuality often resulted in discrimination and poor quality services. Parvati works as a domestic worker, but often is faced with food insecurity and making ends meet to provide for her children. These have become barriers for her to seek treatment. Another significant social barrier to disclosing HIV status and seeking treatment is linked to HIV in her community being equated to a diseased and an incurable body. Women with HIV in her community have experienced being outcast and such have lived in isolation. Right, so kind of giving you a context of if you really are thinking about a story, right? Thinking about the individual and thinking about their lived experience, how does all of this connect? And so I will just, since we can't have a conversation here and I am talking through this, I'm gonna give you my responses in the three aspects, right? First, kind of if it was a traditional approach to health communication, we are most likely going to say to this, right? Let's talk about condom distribution. Let's talk about interpersonal condom negotiation skills. Let's talk about billboards and education about HIV. And depending on the context, maybe even ART treatments, right? From that aspect, from that vignette, you may say, well, actually, there is a social aspect, right? We are not just going to be able to talk about the health behavior and just the individual health behavior risk. We also have to talk about the social environment in which the HIV risk and prevalence is happening, right? So we draw in the social determinant of health. But my point earlier was social in that aspect is often isolated, right? And quantified, and we choose variables. In this case, maybe gender, level of education, income, and maybe even culture as a variable to characterize and predict the HIV risk behavior of that individual woman, right? Ultimately, we haven't moved from the individual health, and social is still separated from the health. What we do, in fact, is seeking explanation, a social explanation of health. So today, I'm going to offer you an approach to think about health and health risks in a more complex and nuanced way. And I'm going to do that by drawing upon two of my studies in the context of Nepal and in the context of China. But before I do that, to answer this question, from that perspective, I would say we need to think about gender relations, right? Where sexual responsibility is attributed solely to women, right, in that story. Cultural practices, where social standing and discrimination of HIV is attributed to women, right? Because men were able to frame it as, right, companionship. Poor medical services linked to cultural discourse around sexuality, particularly female sexuality, and risk and vulnerabilities that are created by unequal gender and economic status, right? So then we start to think about how all of these things, and not thinking about the behavior first, we're thinking about the environment and the culture in the ways in which that is intersected of being a woman and the health risk and health decisions that are being impacted in that sense. So I kind of want you to think about that and put that in your mind, in the backdrop as I talk about more specifically the intersections of culture, gender, and health. And as I said, I'm going to draw upon two of my studies, one focusing on female sex workers and motherhood in Nepal, and the other one focused on unwed single motherhood in China. Right, so here she says, I started this line of work because he was abusive and left. Sorry, I have images in front of me and I can't read it. And I'm not educated. I don't know how to write my name, and I was afraid to look for jobs because he took my citizenship card. I cannot take my parents' name because I am married, so for a long time, I only used my first name. I had no last name. To get a permanent job, I need my citizenship. I have to work in this line to educate my children, take care of them. I work, I survive, and I live. I just wish that no one has to go through the hardship and suffering I have been through, right? So she's talking about gender roles and the implications of gender roles when it comes to health and health risk behavior. She is a sex worker because of social exclusion, because of patriarchal norms, and that prevents her from being able to take her citizenship and apply for jobs, right? Education, lack of education. So all of those gender roles and gender relations obviously have an impact in the decisions that she's making right now about her health. Another person said, well, the best thing is to say no. No service without a condom. But you know, that is not always possible. And why do you say that, I asked, right? Well, sometimes you have only few clients. You have hardly made about $5. So you think to yourself, what about food tonight? What will I feed my children? How will I take care of them? Right? And so here she's talking about negotiated health. The individual health behavior here is contingent upon whether she thinks of herself as a woman, as a mother, or as a sex worker. Much of our work when it comes to behavioral interventions to sex workers, we think of them as sex workers and preventing HIV risk, right? But what the story is saying is that I'm not only a sex worker, I am also a mother. Sometimes my motherhood takes over the choices that I have to make for myself. And the last person said, I feel uncomfortable going to clinics and hospitals. I might go there because of my health condition, but they may think, what kind of person is this? I feel they wouldn't understand my circumstances that necessitates this line of work. They wouldn't understand why I need to do what I do. I may go just for a checkup, but they see me just as a whore and treat me differently because of what I do. I think I will only go to the clinics and hospitals when I have no other choice because of the severity of my health condition. I'm kind of thinking about institutionalized discrimination, and I connect to this idea of what Paul Farmer talks about as structural violence, violence that is connected to health and human rights, that is preventable. Right? And in this case, is connected to discrimination that is internalized, institutionalized in healthcare that prevents somebody from going and seeking that services. Right. Now I'm going to move into similar kind of notion of intersections in the context of China, and then I will talk about how all of this comes together. Right. Here, our participants said, the partner's parents just pressured me to induce abortion. After being rejected, they humiliated me in the community, making up stories to devalue me, saying that I was just immoral and seduced their son because they just felt my baby would hamper his future marriage. Unless my baby was dead, my reputation was ruined and no one would trust me no matter how much I explained. Right? Different context, but we're still talking about gender roles, the impact of gender identity and gender relations on health and health risks that are being presented here. My parents just kept asking me to induce abortion. My mother said I was so unfilial and brought her shame. Kept saying that the daughters of other families would bring back money, bride price to their families, but my childbirth was useless, valueless. Sometimes I feel so tired of living, too tired. Right? Again, identity, right? Is she thinking like a woman? Is she thinking like a daughter? Is she thinking like a wife? And in this case, mother, right? A women/mother because of unwed single mothers, but the same idea of social identity and the expectations of performing that social identity, and therefore the impact it has on health decisions. There are several Dhamma from family planning commissions wearing red armband, inspecting for any illegal pregnancy. When the Dhamma found out that I was pregnant, they kept bothering my family, me and my family, and asking for penalty. They told me get married or just move away. They threatened to charge a huge penalty. Again, institutionalized discrimination, where somebody has an ability to discriminate in a structured and accepted institutionalized way that it prevents you from getting access to health and health accesses. The point here that I wanted to make through these excerpts is that both studies have localized meaning, right? I mean, I'm giving you a snippet of those intersections, and all of the gender roles, gender expectations, social identities are very much culturally embedded. But there's also a connection, right? Even though we're looking at women in Nepal versus women in China, right? That health of marginalized women cannot just be focused on the individual health risk, because there's more happening around them. All of their health decisions, health risks are intersected, right? In all of those aspects that I just talked about in terms of gender roles, social relations, their identity. And in this case, both women in the studies living in poverty, and of course, social policies that exacerbate some of those things. And so really highlighting the point that the intersections of culture and gender in health communication is really important to consider, not as, again, right, an additive variable that looks at all the things, the social meanings of health, but really the ways in which that is embedded in how one can make health decisions, how that increases risk and vulnerability, and the overall impact of health on that individual. All right, so I wanted to end with a conversation about what happens, right? If you wanted to kind of look at this intersectional framework in communication, what are some of the things that we should think about, and what are the things that become important? And I think, the first thing I would say, obviously, is the intersections, really looking at the intersections. And in this particular, I'm looking at social, cultural, and gender inequalities, the intersections of culture and gender inequalities. But embedded in that conversation, right, are also family expectations, the structural limitations, policy, poverty. There's all these other things that are happening. And we really have to think about health, not behavior as first, but really thinking about the individual in an intersected and dynamic way where we place the individual as an individual whole person, not just the behavior that defines them. The second thing is to really start rethinking this process of how do we develop health communication interventions, particularly for people in the margins, right? Do we continue to think about risk behaviors? Connected to my first point, I would say, right, should we then actually focus on the conditions of inequalities that are creating these vulnerable spaces? For example, in the case of Nepal, right, women were outcasted by their husband, therefore their family, therefore their community. When you have no education and you have children, right, sex work became the only means of survival. In the context of China, right, unwed single motherhood is illegal. That prevents women from seeking support. It's connected to saving face and honor in the family and in the community, right? Again, broader social practices that are creating vulnerable spaces. These conversations are obviously much more difficult and much more nuanced and much more historical, but that really tells you where that health is located. And if you wanted to make long-term behavior change, it needs to be really rooted in those intersections. The third thing, which I think is very, very important, and I hope I was able to illustrate this by picking out the stories, is that really centralizing the lived experiences, right? We can only make the invisible visible if we have stories, if people share those stories, if we're able to bring it to this kind of communicative platform, and really talk about the inequalities, right? And the ways in which it impacts health and health risk behaviors for that individual and for that particular community. So centralizing lived experiences and voices are really central to this. And the last thing I would say that is also important is that although it's important to focus on localized contextual meanings, and as I said earlier, right, I wanted to focus on a more micro perspective, but at the same time, it's also important to kind of think outside of that and make a broader global connection. So as I was saying with the stories, right, the intersections are similar, right? There's a shared inequalities of gender and women and gender inequalities that is happening here. But at the same time, if I had time and if we, could have conversations, each of those interpretations of those intersections are going to be very different and should be contextual to that particular culture. I will end here, and I'm happy to take questions later, or if anybody wanted to reach out for additional conversation, that's always an option as well. Thank you.
Okay. Thank you. Now, thank you very much. Can we now move on to Thank you very much. Now, can we move on to our third speaker? Yeah, can we turn Ethan? Yeah.
Yes. Hi, everyone. Just let me get my everything set up here. Hopefully you can see my screen. So, all right. Thanks so much. It's really a pleasure to be here. I know everybody has said that's already a real great honor. Thank you so much for having us. I too, I've actually never been to Hong Kong before. Been to the airport many times, but have never left the airport. So anyway, this is just another reason to come back another time. So thanks, Leanne and the whole crew for having us. It's also an honor to speak after Doug and Icha because they have really set up some really important issues around the notion of culture and health communication. So I hope to build on some of that. I'm going to be talking about speaking holistically, looking at examining cultural codes of everyday health beliefs as yet another way of thinking about and expanding our understandings of health and culture. So where am I going to go in this talk? I want to start first by saying something that I think we all kind of already agree on, so I'll move quickly, but it helps set up the argument, is that we have health disparities. These health disparities are often related to this larger category of stuff that we call culture. There are many different ways to think about and study culture. We've seen a few of them today. I'm going to present one particular way of looking at speech or cultural codes, which focus on community assets and established practices, and then use that to describe a case study that looks at behavior change intervention with established CIH, which is complementary and integrative healthcare codes or practices, and biomedicine. So that's where we're going today. All right, so let's start with, we have health disparities and these are related to culture. So I know Icha also had a social determinants of health slide. Others have as well. I think Doug did as well. So clearly this is how we talk about health disparities. We've gotten to a point where within the larger, I think not just in health communication, but the broader research areas of health, we recognize that health disparities exist and that they're, what goes into that is often these social determinants. So things like your economics, your neighborhood, your education, access to food, all of these things affect a person's ability to maintain their own health and well-being. If we look at, and I knew that Icha was going to talk about intersectionality. So if we look at global health disparities, we see that they are often intersectional. So because I do research on type 2 diabetes, I pulled this particular slide from the World Health Organization saying that for women and diabetes, more than 50% of women with diabetes live in Southeast Asia and the Western Pacific. So at least just two intersectional identities, your nationality and your gender identity, affect the proportion of people who are facing particular diseases. In terms of thinking about racial disparities, and these are particularly, I think, important as we look at the US context, oftentimes the way that you establish that there's an important situation to study is to what I call to present it as a racial disparity race to the bottom. So if you're the group that has the worst disparity, then your study is the most important, right? So if you can show that that your group is affected the most, then it creates this kind of inherent reason why we need to examine that. So I study Chinese Americans and type 2 diabetes. It turns out that actually Chinese Americans have kind of not so bad numbers when it comes to type 2 diabetes. And so oftentimes that isn't the way that I make the argument why this is important. I do think that this is like a problematic thing because I think we should pay attention to racial disparities, but it's as if you don't do worse than the white norm in the US, then nobody pays attention to your research. So for Asian Americans specifically, they develop type 2 diabetes at a BMI level that is actually lower. So, so oftentimes we get this idea like, oh, Asian people, they're pretty thin. They're not going to develop type 2 diabetes. And that is actually a myth. So, okay, I'm not going to get into type 2 diabetes too much today, but I think also that we're at this interesting moment, especially in the US, but I think globally, we're having a racial disparities moment in the US. So this just came out yesterday. The NIH declared this UNITE program, vowing to end structural racism and to do something about it in terms of the way that our government funds research. The APHA, which is the American Public Health Association, has this dashboard up. So there are many different states and localities who are declaring racism as a public health crisis. And so this tracker that you can see here, it's sort of, if it's darker orange, you have more declarations, but this is becoming kind of a marker of you know, one could say how woke you are in the public health world. So these declarations of the public health crisis of racism are one way that you can, you know, show how your state or locality is doing. So I'm located in San Francisco in California. I see that we're bright orange. I'm a little bit not surprised by that, but so you go. Okay. So we have these health disparities. We often relate these things to, and I put in quotes, culture, because I think oftentimes when we think about culture, the most common thought is the idea of race and ethnicity. So I am really excited that we're having this moment of thinking this kind of racial reckoning, thinking about the effects of health disparities on different racial and ethnic groups in the US and more broadly. But I do also think that there are other things to pay attention to when we think about culture. So I have a little, I'm going to do an interactive. I think we have enough time. My question for you all, if you can get to your chat feature, is which of these breakfasts, and I see that there's only 2, but which of these breakfasts are you more likely to eat? So you can just type in the chat 1 or 2. It's very mixed, I see. Lots of people with 1s, some with 2. All right. I purposely picked things that were a little bit different. So the top one, perhaps a yogurt, something. The bottom one, some rice. I know, as a type 2 diabetes person, I should not have put a picture of white rice, huh? I really should have put like some brown rice or something like that. But then maybe culturally you all wouldn't have eaten it. I'm not sure. All right. I think from the chat, it's actually really pretty even split. So my question for you to reflect on here is, why did you pick that? Is it just personal preference? Is it something cultural? Is there something deeper within your choice? Are some of you perhaps lactose intolerant, so you're not going to pick one? That's me. So I'm an Asian person who's lactose intolerant, so I'm never going to pick the yogurt. So is there something cultural about your choice? Maybe we could have divided you by race and ethnicity to see if that factored into it. Perhaps we could subdivide people by nationality or national origin, right? Gender identity or sexuality, age might have something to do with it. Your religion, right? The picture did have some meat on there, so maybe your religion affects it. Or this whole host of other categories, education, language, access, wealth, et cetera, et cetera, et cetera, right? Depending on what breakfasts are available to you. So I wanna ask us to think about, maybe there's another way of thinking about culture. So I think all of us have talked about kind of centralizing the idea of culture within health. These are article or books that have been influential in my own thinking. So Arthur Kleinman, a medical anthropologist, talked about patients' explanatory models, that patients have within themselves a theory of how things should work in the world, and that we should value or be interested in what those theories are. Mishler, who writes about the voice of medicine and the voice of life world, I appreciated that Icha presented her story as micro. I'm like as micro as you can get. So I'm trained as a discourse analyst. We like to record things and then listen to them and then tell you like how short the pause is between one word and another word, and then tell you that there's meaning. And so the voice of life world becomes this way, again, of valuing patient voices, of thinking about where the patients come from, and understanding that there might be these different cultural tensions between people's professions, in this case, like the profession of being a doctor versus the profession, well, it's not a profession, the identity of being a patient. Collins Arahenbua's work on the Penn 3 model, the reason why I really appreciate this is because it focuses on the things that groups of people are already doing to maintain their health. So there's a lot of, one could say it's an asset lens. It focuses on the strengths that people are already doing. And then Mohan Dutta's work on the culture-centered approach, which really values people's own stories and looks at how they can have agency within their own cultural practices and then within oftentimes the limits of structure. So if you want to read more about cultural theories, I think Terry talked about this last night, but Barbara Scharf and I have a chapter in her book that looks at and does an overview of all of these various cultural approaches and theories. So I'm not going to go into that today, but okay, so let's get back to our breakfast. The way that I wanted us to think differently about culture is to think, I gave you one breakfast that could be considered cooling, that would be the yogurt, and one breakfast that could be considered warming. I'm just going to assume that it's warming because you're eating hot rice. Okay, so it's at least temperature warm, but it's also more warming in terms of its like energetic properties. So I'm wondering how many of you in the audience have this idea within your everyday eating practices that foods have a kind of warmness or a coldness quality? You can, you can also like raise your hand too. You can raise your hand, you can drop it in the chat. So let me know if you have a kind of warm, cold properties system within your everyday. All right. Great. Yes, I'm hearing some about warm water. Yeah. Oh, it's like the kiss of death. Being my family's Chinese, and my mom was like, "You cannot put ice in that water. You always have to drink hot tap water." Yes. So yes, I'm seeing a lot of warmness here. So because I do research with Chinese Americans, one of the things that we have found out from them as we deal with food-related illnesses like type 2 diabetes is that there's already existing systems for the ways that they think about their own health. One of those is this notion of warm and cold. So it's an already existing system that works. People assess their own health based on if they are more warm or more cool, and then they make adjustments to their diets based on that. If they are feeling the effects of being too warm, they will eat more cooling foods. Similarly, if they're finding some of the drawbacks of being too cool, they'll add more warming foods, right? If you want to get people to change the ways they eat, it's super hard to do. And yet, if we can find or connect to the ways that they're already doing this, this makes it a little bit easier, right? All right, so I did some field work in Singapore back in 2015. And because my interest is in Chinese medicine, I also, in Singapore, there's like a ton of Chinese medicine, which is great, but there's a whole lot of stuff that I would say too is not really Chinese medicine, but it's this something else, this informal idea of that comes from Chinese medicine, like the notion of warm and cold. So I have a book chapter on heatiness. What I love about that word heaty is that it's an English term or a Singlish term, we should argue, right? So they don't use a Chinese term for this. They actually use an English or a Singlish term called heaty. And I would ask people, so do you use Chinese medicine? And they're like, no, I don't do that. That's superstitious. That's like my grandma. I don't do any of that stuff. And then I would say something like, can you tell me what heaty is? And they're like, oh yeah, heaty's this, right? Oh, you feeling heaty? Yeah, Singapore's super heaty, right? So there's definitely this hard separation between the formal practice of Chinese medicine and these everyday practices that I think are so ingrained in the ways that people see the world that they don't even think about them as quote unquote healthcare. So this goes back to my interest in complementary medicine. So the WHO put out a report in 2019. They're really interested in surveying all of the WHO member states to see how many countries formally acknowledge traditional and complementary healthcare usage. Although the number is 88%, really it's probably 100%. It's just that not all the member states actually filled out the survey. And so what it's saying is that people all over the globe are using complementary medicines. And this chart, which I think is like actually not very numerically literate the way they've done it, but it's the number of member states who say that they have people in their country that are using these various different things. So it makes it look like everybody in the world is using acupuncture, but it's just the number of countries. So because there's a lot of different countries, it's not really the number of people that are using this many. But I will say that some of the really high ones are acupuncture, traditional Chinese medicine, and then it's got this notion of other. And the reason why I circled traditional Chinese medicine and other is because I wonder this idea of like warmness and coldness, does that fit within this survey? So if you're a person that believes in the warmness and coldness of food, is that using traditional Chinese medicine? Is it using quote unquote indigenous health practices? Is it quote unquote other? Or my guess is likely it's not anything, right? It's not considered one of these different things, and yet it's so central to many of our cultural ideas. So I would say maybe we can examine it as a cultural code for communicating and experiencing wellness. So this is a different way of thinking about culture. So as I've presented many different ways to think about culture, I want to focus in on this idea of what does it mean to have a speech or a cultural code focused on community assets and established practices. So one of them, this notion of hot and cold, can be one of them, but there's many. And obviously every community and every cultural group maybe has their own. So cultural or speech codes comes from communication studies, and it's a micro look at practices. I think oftentimes when we think about culture, we're interested in what are the cultural groups? What are these people doing, right? And I think as I'm like fully trained as a communication scholar, I'm actually interested in what's the practice like. So speech codes come from a scholar named Jerry Phillipson, and he says that speech codes are a system of socially constructed symbols and meanings, premises and rules pertaining to communicative conduct. So specifically, Phillipson is not a health researcher, right? He's always been interested in what are these codes for understanding people's talk or understanding people's communication. But I think that we can actually look at this in terms of health as well. If we focus on what are the practices that people do and less focus on who's doing it, I think it gives us this much more micro practice to be able to then build behavioral changes. So, oops. Let's see. So I've been working in this area my whole career, which is not super long, but I think is sort of long enough. So at least 2 decades, I've been looking at the micro practices around Chinese medicine. So we can look at symbols, important symbols like the idea of qi. We can look at rules and norms. So recently I wrote a paper that looks at intergenerational soup making. So these everyday practices, if you are in a Chinese household and your grandparents are teaching you how to make soup, one of the things they're going to teach you is how to skim that scum right off the top, right? And if you're lazy and Americanized, as I am, sometimes I skip that step. And my mom is like, that's how you're going to get sick, right? Like this is an important practice or an important norm. Meanings, you can look at things like holism and whether or not these are contested meanings. So I think by bringing this idea of cultural codes, what are the systems of socially constructed symbols, meanings, premises, and rules, it can be a way of looking at how people frame and explain how they do their own health or how they work towards their own wellness. So with that in mind, there's been quite a bit of research that has looked at applied cultural speech codes. So in many different areas and contexts. So Lisa Rudnick and her team looked at disarmament research. Darnell Carbaugh and his teams have looked at human machine interface. And then there's two examples I think that I know of really that are looking at health, which is my work as well as Cecilia Rossigno's, who's looking at clinician-patient communication with parents whose children have had traumatic brain injuries. So I want to spend just my last couple minutes talking about integrative behavior change and patient education. If you recognize this, it is a bitter melon slice, which is the logo for our research project, because it turns out that bitter melon is super good for you from a diabetic standpoint in both biomedicine and Chinese medicine. So we think it's a really great symbol of this. All right, so integrative nutritional counseling is a program that me and my research team have worked on for the last decade. I don't have time to get into all of it, but essentially we're trying to mix what's the best parts of Western medicine and the best parts of Chinese medicine. And I don't mean Chinese medicine like herbs, but I mean this kind of Chinese medicine idea of eating. So we have things like, instead of using a plate method, which comes from biomedicine, we use a bowl method because most Chinese people that I know eat with a bowl. And then we use this idea of warming and cooling and categorizing fruits and vegetables as warmer or cooler as a way of encouraging people to eat more vegetables. So with type 2 diabetes, as you might know, you want to try to avoid eating carbs as much as possible, or reduce your carbs and increase your proportion of vegetables. We think that if we can get people to use their existing belief systems around, for example, warmth and coldness, then they're more willing to eat maybe a vegetable that they wouldn't want to eat. So I have all kinds of slides if you're interested. And then we also encourage people to check their digestion, because for a lot of Chinese Americans, at least in our research, they use digestion as a way of measuring whether or not their diet is sort of suitable to them. So if their digestion's off, then they'll on their own make dietary changes. We've studied a variety of different outcomes. I just want to encourage you all that those of you that are interested in culture, you really can still look at those notions of culture. And if you're a health comm person, you can study health outcomes. So it often takes many, many years. And I just put this here to say that, like, when we first started doing this, we couldn't really look at health outcomes, but the longer we were doing it, we've been able to build up to looking at health outcomes. So it's something that you can do in the long run. Thanks so much. Yeah, happy to take questions, and check out our diet guides at inkguide.org if you're interested. Thank you.
All right, thank you very much, Evelyn. Yes, so now we will open the floor to everyone to ask questions. You can ask either by unmuting, or you could also type it in the chat. But maybe we'll start with Leanne, because she has a question.
Because she has a microphone. Okay, so thanks to all the guest speakers. Thank you for sharing the different perspectives on culture. So I have this question for all three of you, and actually I ask these questions on behalf of my students, because when it comes to some kinds of research, when it comes to cross-cultural studies, or if you are applying the similar theoretical framework to different cultures, then you may face these issues of standardization, variation, and contextualization. So I know that you did your study at the different levels, and then you have different focus. But then I would just like to hear more of your reflection regarding so when it comes to, for example, cross-cultural studies, or when you have to apply the similar theoretical framework into different cultures, then how do you address the issues related to standardization and the variation across the different contexts? Thank you.
Do you want to take that first, Doug?
Sure, if you like. So a lot of the work that I do is based in social psychological theory. It focuses largely on individual behavior, but it acknowledges that those behaviors occur within context, and that it's important to understand how the shape of those behaviors in particular in different contexts, including situations where extreme disparities exist in some cases, and lack of access to resources you need in order to act in your best interest. But I think the way that we tend to approach that is to think of some of the core constructs in social psychological theories, like risk or self-confidence, or awareness of and sensitivity to the behaviors of others around you, the social pressures that you see in your near social world. We recognize that those things will vary in the way that they're expressed and the way that people talk about them from one context to another. So we try to sort of branch out from some of those core constructs to understand what risk means in a particular setting or for a particular group of people. You know, what their own personal concerns are about fitting into their social environment and being accepted, and you know, many of the things that Icha was talking about. And to I really enjoyed both of those presentations. You know, we don't go as often go as deeply into the cultural and ethnographic detail as you do. In some cases, in many cases, because we are trying to, most of the projects we work on are large population-based programs. And so we're looking for more generalizable principles that may have effects on larger groups of people, you know, health at the population level, as opposed to health in a more localized sense. So that's the balance that we try to strike. It's not easy. We don't always hit the mark, but we do try to contextualize some of these core constructs in local settings from the perspective of those who are you know, trying to manage their health.
Because it's also like, if you know, you can keep certain level of standardization. I mean, you know, by the inclusion of certain, you know, ideation factors that can allow you to do more comparison across, you know, different cultures. So then that's how I interpret, you know, Doug's approach. If my interpretation is correct.
I should point out that this global survey was translated into the languages of the countries in which the survey was done, and thankfully, we didn't have to do that. Facebook took on that responsibility, and it was a huge task to ensure that these standardized questions were translated into a form that made sense to the local respondents. Yeah.
The variation actually emerged from those, you know, standardized questions. If we understand, you know, culture difference in that way, right?
I think so, yes.
What about Icha and Emily?
You want to go first?
Oh, sure, I can.
Go ahead.
So I think that I have always been interested in this issue of standardization versus obviously like a local context. And one of the things that has become really interesting in our work looking at, so we create these programs for Chinese Americans. And at the same time, there's a ton of people in San Francisco who are not Chinese American, but who use Chinese medicine and are really interested in the principles of Chinese medicine. So the idea of hot and cold, for example, and changing your diet based on that is really, really resonant with also, for example, very wealthy, educated white women who are sort of very health conscious as well. And so I actually think that what's interesting is that we can see standardization differently, to say that it's not always tied to a particular cultural group, right? So there's something standard about this idea or this practice, and that itself could actually be applicable in other communities or other groups, right? So that's just one example of that. But at the same time, we do get criticized sometimes by hardcore, I would say, Chinese medicine people who are like, you can't be making these crazy standardized diets because that's not how Chinese medicine works, right? Chinese medicine works because it's an individual receiving an individual diagnosis at that moment in time from an expert. So I think it is true, if you want to reach a bigger audience, there's always going to be some corners that you have to cut, but I think that there's benefits in doing that, even though I laid out this whole thing about how we should be, you know, locally specific too. So.
Yeah. And just to piggyback off what has already been said, first, I mean, I really enjoyed both of your talks, because I think the three of us are so different in the ways that we think about culture, that it's important to also make a point here that there is no right way or one size fit response or approach to it. It really comes down to what question are you asking and what is the objective we're trying to achieve here. So if you think about the three of us, we have really different, I mean, we're looking at culture and thinking about culture, but we're looking at it from a very different objective, because we're looking at, you know, really kind of thinking about it from a broader sense to a very micro sense to even, I mean, I was thinking micro, but Evelyn's even more, right? Thinking about language and culture codes, and it's in a layering. And there's like, so if you think about it's a nice layering of kind of thinking about how, right, there's this big idea, and then we can just kind of take that slice of it down. But from my perspective, I would say, I am very careful, right, obviously, as the qualitative person, to say standardized and to say cross-cultural, because the idea is that I am really interested in the micro spaces and the meanings. But as I said in my talk, it's also important, particularly because I'm looking at marginalized spaces, to talk about shared experiences. So I often think about it as shared experiences as opposed to comparing those experiences, because that experience and how that's localized or how that's understood in one space and what that means is not going to translate exactly into another culture, but there are shared experiences of inequalities and marginalizations. And so I often think about it, if we really do have to compare, like I did in a way compare, right? I was talking about women in China versus women in Nepal, but you know, it was more broader shared intersections. But as I was saying also, if we really talked about it in each study, the interpretations of it are very cultural. So I think those nuances are always a need to be there, and again goes back to really what is it that we want to get looking at culture in that study.
So thank you. Yeah. So Doug, you want to join? Yeah. Oh no, right?
Sorry,
Okay.
I was going to say there's an interesting question in the chat.
Yes, that's right. I'm going to read it out now. So
Okay.
yeah.
Yeah,
So basically, this question is on because yesterday the speakers talked about whether doing research in specific contexts. So the question was that it was a very difficult job because most of the theories that were based on were developed in a Western context. Do you have any specific suggestion to make the research more fit into the Chinese context? Yes. Yes. Please go ahead. Yeah.
Well, I was going to go ahead.
No, go ahead, Doug.
No, I was going to say I have a very dear colleague in Pune, India, Nandita Kapadia Kundu, who, when she did her dissertation many years ago, used the Indian philosophy of Sadarnikaran, which is in a sense an Indian communication theory. And it includes constructs that are not found in most of our Western theories, theories of compassion, theories of respect that we don't usually have in our models. And I know Confucian philosophy and Buddhist philosophy also have concepts that are directly related to communication and to how we relate to each other as humans. And I think that may be, there may be some origins of really interesting new theorizing that can emerge from those perspectives.
I was going to say, you know, in the studies that we have done in Singapore and looking at Chinese context, we have, as Doug was suggesting, looked at cultural meanings and cultural phenomena and cultural words that help us understand what is going on. But I've also, you know, done studies looking at Western theories. And I would say, like, in those kind of studies, and maybe it's easier as a qualitative interpretive studies because we're not testing, measuring anything. You are trying to understand it to also point out the differences in the ways in those concepts apply, right? So if, for example, recently in a study that I looked at in Nepal, I was looking at really power in entertainment-based workers, right? And the ways in which gender power works. And it's a sociological concept from the West. But then, part of my argument was, how does those ideas play out, right, in Nepal, and how can that context also inform that particular concept and the ways in which we theorize it? And I think, and again, as I said, it's easier because I'm not out there to test that and see if it applies in that context. So it's easy for me to say, yes, right, let's look at those nuances. But I think this is particularly challenging for scholars who are post-positivist and want to maybe look at models and theories that, do that. But I think, and I think from a cultural perspective, we would all say, right, even if you take that model, don't take it wholesale, right? You are going to have to adapt it to that cultural construct and conceptualize those constructs, as Doug was suggesting earlier, to that particular culture, right? The languages, the words, the localized meanings of those constructs or words. And I think that's where you start making those changes too. It's not, let's take it and try it here and replicate it. It's how do you actually tease it out and make changes so that it represents that particular cultural context. So even for post-positivist work, I think it's possible. Yeah.
Thanks. Yeah, I'll just jump in I agree with everything that's been said already. I think some of this, it's a really great question though, because I think oftentimes, especially for students and young scholars, you're constantly going to be asked, what's your theory? And I think sometimes that question really is, what's your theory with a small t, not what's your theoretical perspective. So I would encourage you to really think about, like, what's your theoretical perspective? Are you coming at this, as Icha said, from an interpretive perspective? Are you coming from a critical perspective? Are you coming from a post-positivist perspective? Because that theoretical lens is actually going to be different, right? And so if you're trying to fit like a small t theory that does come from the West, that really was created for explaining things that are happening in the West, then it maybe isn't a good fit. But the other thing I would say too is that we really do, the world is so transnational now that I don't even know if I can believe that those are quote unquote for the West, right? And so what I mean by that is that when I was in Singapore, there were people there who were more scientific than the people I encounter in the US, right? They were like, why would you look at Chinese medicine? That stuff is so backwards and ancient and unscientific. And I was like, wait a second, I came to Asia to like learn about this, right? And so we have these interesting spaces where people who are in the West are actually less West than people who are non-West, right? So I actually do think there's a lot more movement around this. And so paying attention to those local contexts of what's happening allows you to maybe see the influences of all of these different factors that are going on.
Do the other speakers want any last word from the speakers? Okay. Otherwise, thank you very much, and I will really appreciate if we have the opportunity to have you in Hong Kong in the future. So now maybe take the opportunity, for photo taking. Yeah.
No. For all the panel, we want to take the group feed together. So if the audience wouldn't mind, could you open your camera so then we can take a group feed together? And also, I want to thanks again to the three speakers today, because they are doing something related to culture, and then their studies, other scholars they are also doing very meaningful work, but then they are also doing very meaningful work too. So thanks for sharing your insights. And then today's speakers, they have nicer background. Yesterday's speakers, most of them they locked in their basement. So so we hope that next time we can invite you to Hong Kong.
Okay.
So yeah. For the all the other participants, thank you for being here. And if you don't mind, could you also turn on your camera so then we will take the group together. Yeah, it's okay. We can do. We need to stand up. Yeah.